This is uh, this is Dr. Mohammed Al-Muhammadi, an interventional cardiologist at King Fahd Medical City, head of interventional cardiology there, and with a great interest in primary prevention as well. I'll be chairing this session in association with the Saudi Heart Association regarding lipid management and the importance of understanding the LDL in clinical management. It's with a great pleasure to introduce Professor Pascal. He's the Director of Department of Advanced Biomedical Sciences in Federico II University of Naples. He's a Professor of Cardiology at Department of Advanced Biomedical Sciences. He's the Director of Cardiology Inpatient Clinical and Director of Outpatient Clinical Program of Cardiomyopathy and Pulmonary Hypertension. I do believe that his list and CV is needs a session by itself. So I'm just gonna summarize it. So he has a very high impact score, more than 2,200, with a high index and citation almost 50,000. It is a very great pleasure to have you with us here in this session.
Thank you so much.
So we're gonna kick off this session by doing an introduction from my side, a quick presentation talking about the importance of the LDL management in the clinical practice, and then we'll give you the mic to take it from there. I believe we all have been encountered patients who, in our practice, who would be more challenging in managing LDL. However, do we actually give it the same importance as other cardiovascular risk factor? And we'll dive deep into that factor. Coronary artery disease or atherosclerotic coronary vascular disease, cardiovascular diseases are multifactorial, and we all understand that there are the modifiable factors, there are non-modifiable factors, but we can also stratify it as environmental risks that we cannot technically control. And then there is the metabolic risk, which we can actually have influence on, and behavioral risk, which is also more challenging, but also we have some control over it. So lowering the LDL seems easy, and it is in fact the most effective and safest option to reduce the overall risk for your patient. The global burden, I think we don't need to talk about that because mortality from cardiovascular disease still ranking number one in many countries and nations. So how about if we want to talk about LDL specifically in a subgroup, and we can see here the higher LDL overall, especially if it starts early in life, that will increase the cardiovascular disease risk over a lifetime. And that shows nicely in this graph with the patients who started early having high LDL with multiple risk factors, and we see the patient in the lower side that have better control over LDL and cumulative events they have throughout their lifetime. And especially in our area, maybe it's different in Italy and Europe, but definitely in our area, we encounter these in early ages. The optimal risk profile for these patients with two or more risk factors is even worse. Usually, patients do not come with isolated hyperlipidemia or dyslipidemia. They do quite often have multiple cardiovascular risk factors. And unfortunately, we still struggle in controlling their LDL profile. So, for example, here, 45-year-old people with optimal risk factor profile are more likely actually to live 14 years longer compared to patients with two or more risk factor. And that tells you the burden of the disease. The substantial lifelong LDL reduction basically is why we're meeting today, why we're doing these meetings 2, 3 times a month. And we can see here by controlling the LDL, you're actually affecting the patient longevity and the clinical outcome and decreasing the burden on the health system. So the cumulative exposure of an artery to LDL over the years is a principal determinant of disease initiation and progression, unfortunately. So, which is has been all of this, all of the above reflected in the guidelines, and we're talking mainly here on the ESC guidelines. So in 1988, the goal was less than 3 millimole. And then in 2003, it was 2.5. In 2007, it was a moving target, 2.5, less than 2. And then moving from 2011 to 16, the goal was 1.8. And since then, we had many data to show that lower is better. But the guideline kept it with moving targets in 2019 1.4, that the one we most of us kind of follow. But then you have the very high risk patient or even the extreme patients with a target less than 1 millimole. Obviously, this is one of the earliest trials for statin therapy, and that was done for pravastatin back in the days with a 20-year follow-up of around 6,500 patients. And unfortunately, the earlier the better. And if you missed the opportunity to control the LDL, basically, you miss it forever. We know that atherosclerosis, the moment it starts landing on the coronary arteries, is basically stay there to stay. And many data now may be showing that some of the PCSK9 inhibitors that can give a potential disease regression. However, as for now, if you develop some sort of atherosclerosis, you're actually going to have it for life. And we can see here the cumulative events over 20 years follow-up period for all causes. Patients who has been controlled in pravastatin actually had a better outcome with a very significant p-value, and specifically for cardiovascular disease. So unfortunately, most of our patients have uncontrolled LDL level despite knowing the guidelines, despite knowing the importance of LDL, but we still struggle. Majority of adults, around 73%, did not achieve even the 2019 ESC LDL targets, which was around like 1.8, 1.7. And the benefit of having lower LDL as soon as possible basically affects the end results or end outcome. And patients from the PCSK9 inhibitor studies, it was found that patients with the mutation in the PCSK9 gene had 88% reduction in the incidence of coronary artery disease. And that kind of gives the hint that this medication may be powerful to alter the outcome of these patients. And we do talk a lot about type 2 diabetes, but in type 2 diabetes, maybe the best thing you can do on top of controlling their type 2 diabetes is the reduction of LDL, as it's one of the most efficient intervention to reduce cardiovascular disease. The combination of dyslipidemia and diabetes, basically, it's very ugly combination for the patients to have, and we're gonna dive deep more into that. So we see here that patients with high LDL is unfortunately surveying the physicians between smoking, diabetes, and high LDL. Despite all these data and all these numbers, high LDL ranked number 3 after smoking and diabetes, and of 5% of the clinician would not set even a goal to reduce the LDL. So that's kind of the gap we have in our clinical practice, the unmet gap that we are struggling with every day, especially me as an end user in the cath lab. We see the outcome of this kind of leniency in not controlling the LDL. So there are all kind of charts, all kind of recommendations. Everything was made very easy for the provider, despite either a cardiologist, internist, or family medicine physician, to make the decisions very clear. But we're going to focus a little bit also on the diabetic patients. So in cardiovascular we do the cardiovascular risk assessment in patients with very high risk cardiovascular disease. Starting high intensity statin ezetimibe would be the first step. If there is significant reduction more than 50% or LDL less than 1.4, then you should be good to go. But if you did not meet these two criteria, then adding a PCSK9 inhibitor would be, by guidelines, the next important step to move forward with. If the patient is extremely high risk, and this definition kind of coming more and more, the extremely high risk patients who had recurrent events or having very high risk profile of having acute coronary syndrome, starting statin, the triple therapy of statin, ezetimibe, and PCSK9 would be the first step. How about diabetic patient? These patients, as we mentioned, they carry a higher profile in terms of risk, and starting statin and ezetimibe immediately would be the most appropriate step. But then moving forward with a targeted therapy with PCSK9 inhibitors. And then we can dive more into the residual hypertriglyceridemia and treating that. And as we're gonna hear more and more at the end of this year about lipoprotein A, then maybe this will have a potential future in the algorithm as well. We can see here how diabetes can be actually can affect the outcome significantly. Patients, the charts in the left here, the individuals with diabetes, and you can see the cardiovascular events almost 14% compared to which is doubling compared to the ones on the right side without diabetes. So we know that the factor of diabetes on top of dyslipidemia can be a potential poor outcome for the patients. This is ACS for patients who were admitted to the hospital, and again we kind of illustrating the point that in the I would say this color is burgundy or the red color. The diabetic patient had the highest incidence amongst all these patients. Unfortunately, despite saying all of that, with these high-risk patients, only 18% of very high-risk group patients achieved an LDL goal less than 1.4, which is the targeted recommended by the guidelines. So meaning we failed to treat or achieving the goal in 82% of our patients. And that kind of tells you why these kind of reminders through webinars and what's not is very important to kind of illustrate the risk and the unmet gap we have. Using a combination therapy is associated definitely with improved in LDL management. We talked about this, and this has been proven in multiple studies. And we can see here that 1 year follow-up in combination therapy dropped the achieved the target goal in the patients almost to 50% of them. So this is kind of a score for diabetic patients. We're kind of making the point here about the combination of diabetes and dyslipidemia, and the score make it easier for the physician to see where they can categorize their patients. And this score was developed as an extension for a score 2 algorithm in patients with diabetes. And we can see here that more than 20% would be considered very high risk patients, especially with target organ damage. The conventional risk factors basically age, smoking, blood pressure, and lipids, and the diabetes related variables added to that is the GFR and the A1C. I want to give you an example of very high risk patient without a previous events or a covenant of events, so you can know what we are talking about in very high risk patients. Score 2 patients more than 20%, which is the very high risk group. For example, a 69-year-old female, type 2 diabetes, 19 years, does not smoke, with a blood pressure that's not controlled, and total cholesterol almost reaching 200, with an A1C of 7.2 and a GFR that less than normal. So this is an example of these patients, and unfortunately, when we see this profile, we don't actually treat them as very high risk group since they did not have an event previously, and we become more kind of forgiving and not targeting the appropriate LDL. So this would be my last slide, the importance of cardiometabolic collaboration in clinical practice. We do unfortunately work in solo practices, but I think these patients would be more appropriate in a kind of a multifactorial approach to the chronic process of high risk prevention, meaning standardized programs with a 2 3 visit per at least during the first period of treating. The team-based approach in terms of physician, nursing, dietitian, physician assistants as well nowadays, and focusing on the evidence-based target guidelines and value. And in complex cases, maybe you want to utilize outsourcing for bariatric, diagnostic cardiology, nephrology, and vascular surgery. This is kind of a complex disease, especially if you put it all together and focusing on the patient in the middle with all of us as provider around them. Hopefully, we can achieve the better results and improve the outcome for our loved ones. Thank you. So before moving to Professor Pascal's presentation, I just want to highlight if you have any question or comments, you can drop them in the chat. So we're gonna have 10 minutes Q&A at the end of this session. Without further ado, Professor Pascal, the mic is yours.
Thank you. I hope you see now my screen. Do you? Well, first of all, thank you very much. Thank you, first of all, to Professor Amom Madi. I'm sorry if my pronunciation of the last name is not perfect.
You got it.
I apologize for that.
Right.
And for this very kind presentation. I'm much pleased to be with you tonight. I was traveling your country last year, and I would have loved to come back again, and I hope I can do this in a future. And the first time I came to your country last year was amazing experience for me, and so I really have your country in my heart. So,
We'll be honored to have you again.
well, thank you so much. There will be chance, I'm sure, soon. So the topic is very important, as Professor Mohammed was introducing very nicely in his presentation. And in my presentation, I would expand a bit on that and also sharing the experience that we do in Italy, where we have a special regimen for reimbursement of PCSK9 and injectable drugs. And so we can made some experience or real life that I would like to share with you. So, as Professor Mohammed was telling us, we have different pathways to follow for optimal LDL reduction. We need combination therapy, as he said, in many patients, and we need triple therapy in most patients that do not reach the target. And of course, for these PCSK9 inhibitors are very keen for optimizing therapy. The timing is very important, not only I believe for the ACS, from a pathophysiological standpoint, of course, we know that the earlier we start in ACS, the better it is, but also in chronic patients, because at least in Italy, the optimization of chronic patient is not that good. And so, therefore, anytime we meet an SCVD patient in a chronic phase, we should optimize the therapy, even in that case. The intensity is now well known that intensity, there is no lower extreme for LDL cholesterol. The lower, the better, and the ESC guidelines were already going in the direction of further lowering the target in the extreme risk population, and I'm sure that's the way we will go in the near future. And then we have, of course, to maximize the effects and to keep the effect long life, and therefore drugs with high adherence and efficacy maintenance like the PCSK9, at least in our experience, but it's are very important. So For the guidelines, the ESC guidelines, there is a very much difference here with the US guidelines. As you know, the US guidelines do not recognize any category of patient at very high risk in absence of previous acute ischemic events. That's the biggest difference with the European guidelines, because the European guidelines introduced the very high risk population without a previous cardiovascular ischemic events. That's very important because from an epidemiological standpoint, this is a much larger population. It's the population in which, in absolute terms, the majority of ASCVD acute events occur, and therefore taking care of this population, considering this population the same level of risk of the patients in secondary prevention, is the new frontier for cardiovascular prevention. And in addition to this, they gave us a clear presentation, even in this figure, of the extreme category of risk. That means patient with recurrent events despite the background statin therapy, or patient, the very large category, with polyvascular disease, meaning ischemic disease, atherosclerotic disease in more than one body artery system. So this is the background that we now have for cardiovascular prevention in Europe. And you see here that the identification of this important category of patient is not only patient with ASCVD, any kind of ASCVD, even the presence of high coronary calcium on a CT scan, or subclinical coronary artery disease in a CCTA, for instance, and or a coronary or a carotid artery disease more than 50% stenosis. So inclusion criteria that certainly broaden the population at very high risk. But in addition to patients with ASCVD, they include diabetic patients as the one that Professor Mohammed was very nicely describing, the increased risk of diabetic patient that is still there, or even nowadays. And then these are included in this categorization. And also patient with a very high score ranking. For it's the system we score the cardiovascular risk. And finally, patient with severe kidney disease. So it's a very important population. Polyvascular disease, together with diabetes, is the main comorbidity, the main characteristics, I would say, for very importantly increasing the risk. You see here from the Odyssey trial with alirocumab how important in terms of risk, baseline risk, is the presence of one or two or three vascular beds. And you know that lowering cholesterol provides increasingly higher absolute benefit despite similar relative risk reduction. You see here the absolute risk reduction is very high, occurs when you go to higher and higher baseline risk population. We understand whether this recent paper in the New England, the AIDS paper, was a South Korean paper that was made in a large population of patients with established ASCVD, and they were comparing two regimen of therapy, lowering with an intensive approach using statins plus ezetimibe, not PCSK9, or a more lenient approach, let's say conventional clinical approach. And the primary endpoint was a combined endpoint of MACE plus coronary peripheral revascularization or unstable angina revascularized, hospitalized in a 3-year follow-up. So the primary endpoint, and that's the important thing, occurred in the 6.6% of patients in the more intensive group that was aiming at reaching the LDL less than 55 target. versus 9.7 in patient with the target of less than 70 milligram per deciliter. And therefore, that demonstrates that any kind of LDL reduction is very important with a hazard ratio for the primary endpoint of 0.33 reduction of the endpoints. But if you look at the achieved LDL in the during the trial, this was 56 milligram per deciliter in the intensive target group, demonstrating that even if you intensively optimize oral therapy, as in this study, because they don't have the LDL, the PCSK9 inhibitor, you don't get to target, don't bring to target half of the patient that remain above the median of the 56 milligram per deciliter. So we really need, of course, to increase therapy with other drugs, and therefore injectable drugs are very important. And on the same line, it is also an simulation, statistical approach from the Da Vinci study of Koch-Ray. And he demonstrated here that in patients, please look at the right-hand side of the slide, patients that were not reaching the target, if you put ezetimibe, you only get less than half at target because, of course, ezetimibe reduces cholesterol by no more than 20%. When you add PCSK9 on top of a statin, you get to target up to 93% of patients. So how this new approach work in real world? And so we recently published with Dr. Batt and a group of investigators from Europe, we made an analysis on a database from the US. And we took from the administrative data patients that without a previous event, but with ASCVD, we took patients that were taking PCSK9 and compared in a 1 to 2 propensity score matching to patients without PCSK9 therapy. And these are the characteristics of this patient. 15,000 taking PCSK9 MAB versus 30,000 that were the propensity matched population. And you see 39% that diabetes, coronary artery disease was of course, the majority was coronary artery disease. Look at this. Coronary statin, any statin was used in 60% of these patients, indicating how still we are suboptimal for treating these patients. And then the median LDL, instead of the 55 milligram per deciliter that we would recommend, was 127, more than double the target that we want to reach. These are the results of the study. Very nice results. The primary endpoint was a combined endpoint of all-cause mortality, myocardial infarction, and stroke, was reduced by 30% relative risk reduction. Very similar to the randomized trial that I will show in a minute. And of course, we did a falsification endpoint to verify that there was no bias in the population, that was, of course, not influenced. And the other thing on the right bottom side, if you put the observed reduction along the meta-regression line of the relation between LDL cholesterol reduction and reduction of cardiovascular events from the CTT meta-analysis people, you see that it was perfectly fitting along the meta-regression line. So this approach is approach that is working very well in real world setting, and same time, actually, I would say that we published this paper in beginning this year. The Vesalius trial was published late 2025, and you see here the same population without a previous cardiovascular event. one of the two primary endpoints, the 3-point MACE, 25% reduction, relative risk reduction, very, very close to what we observed in a different real world population. So the message is very strong. It comes from real world, comes from a randomized study that was also showing, as we did also, I'll show in a minute, a signal for a reduction of all-cause death, and that indicates that this is a very powerful approach for risk reduction. Here, from our study of the real world, is the population treated with alirocumab. And you see here that the same as of the whole population, relative risk reduction was observed of 32.4%, 6.9 absolute risk reduction. But please also look that all the single the individual endpoints were significantly reduced, non-fatal MI, non-fatal stroke, and non-fatal MI more than non-fatal stroke, but also all-cause mortality that was significantly reduced. So exactly the same evidence that we got from the Vesalius study. That's very confirmatory of that. Now, for alirocumab, we have a new, not new, we are using this since a few years now, the possibility of a monthly injection over the 300 dose. And that was studied in a randomized trial, the Sydney multicenter study that was testing the new device that patient take for injecting 2 milliliter of corresponding to 300 milligram of alirocumab every month. And this was a randomized study in patients with heterozygous familial hypercholesterolemia or high risk with more than 70 milligram per deciliter of LDL cholesterol. And it was a quite complex randomization, but those are the results. The 300 milligram monthly injection was reducing LDL by 66.2%, so very high efficacy in this randomized study. In Italy, I have the privilege of running a multi-center registry of real-world data that I founded a few years ago, and you'll see in a minute other data. And we are also looking at the Italian population, taking the 300 milligram per month, and we presented last European Society of Cardiology this first population. Actually is the same size of the population you have seen in the randomized trial in a real world observation. LDL, median LDL at entry 114. And look, we got the same, you remember, was 66% in the randomized trial, was 70% in our observation, and 82% of patients starting with a baseline LDL of 114 reached the less than 55 milligram target. So we are expanding this population, getting extended follow-up, but at the moment, the data that we have are very confirmatory of this very first observation. So the guidelines, what they say? They say with the very high level of recommendation that we have to treat patients in primary prevention, level 1, and class of evidence A if these people have more than 70 milligram per deciliter, and even consider to treat them if they have more than 55, that will be the target, if with a level of evidence 2A. So they were preceding these two studies, our real-world study at the Vesalius, and they were right because these two studies were very confirmatory of what the guidelines were suggesting. But we need to score and to identify these patients, and of course for this is very important imaging, and so very, to me, rightly, the guidelines updated the use of CT and CCTA that we are increasingly using in Italy to identify subclinical coronary atherosclerosis that would make you fit for the category of very high risk and therefore potential candidate for therapy. Shifting very in the last part of my presentation, shifting to the ACS world. The ACS world, we know very well that the timing is very important for prognosis. We got this recent information from the Sweetheart registry. These were patients, a lot of patients, more than 46,000 an MI that were treated not with PCSK9, but with starting high intensity plus or not ezetimibe. And they were divided in 4 groups based on the non-HDL target achievement. And you see these 4 groups were patients that never achieved the target over a 1-year follow-up, or achieved an early target within 2 months from the MI and kept on target, or patients that achieved the target but then they lose it over the time, or they were achieving the target late on the year of follow-up. And you see here very clearly that the intensity and the timing, the early and sustained group is the best, is the better outcome, and this is highly significant. And you see here, this is significant not only for MACE, but also for, once again, all-cause mortality and myocardial infarction. So very important data, but at that time, the Sweetheart was not reaching as a median of LDL. This 55 milligram was stopping the median at 70 milligram per deciliter. So these data were not available for patients at the actual currently recommended target. In Italy, we can prescribe and reimburse injectable therapy based on a prescription that can be done by hospital centers that are allowed to prescribe and make the online reimbursement plan. And for this conversation tonight, we have this kind of approach, the so-called fast track approach, that allows us to immediately prescribe PCSK9 when a patient comes with an ACS and he or she has a LDL more than 70 milligram per deciliter within the 30 days before the ACS. So with this approach, we could recruit this population in the registry that I'm running, that started with 9 centers. Now we are more than 40 centers participating. And this is I would say, I can say, the only real-world study with PCSK9 in ACS, that multi-center study from real world, that demonstrated an outcome difference in patients treated with the PCSK9, either Evo or alirocumab, in this context. And these are the results. Patients were divided, patients were prescribed PCSK9 within the hospital stay, or in the 4 weeks, a very minority of them in the 4 weeks thereafter. When we divide the patient based on reaching or not the target, look at the differences here on the 3-point MACE of death, all-cause death, non-fatal MI, and stroke, and also, as we have just seen for the Sweetheart registry, for all-cause mortality in a 11-month follow-up, that exactly the same follow-up of the Sweetheart, because these are patients very, very high risk, and so a lot of events accumulate within 1 year, and if you lower cholesterol, you are able to see a difference. But even when we divided patients based on the median LDL, that was in this study 43 milligram per deciliter, so well below the recommended 55 target, so going lower than the target, and that's the point. Look at this, you still get a lot of benefit if you go less than 43. And this was reproduced in a smaller study, single center study, in Italy. My friend, Professor Patti, was reporting his experience, and he was comparing the treatment approach in three different time periods. Please look at the green bars. The green bar is the most recent period, January, June 2023, when he was using a personalized, based on the fast track possibility, a personalized patient to patient approach to dismiss, to discharge patient if needed, not all of them, with PCSK9. And so this latest population reached an LDL median of 47, very close to my 43 that I showed you before. And look how the events were, reduced by this approach and by bringing cholesterol below the LDL target. So what the guideline of ACS do, I'm not happy with this because they make a generic, support for intensification on lipid lowering for patients were on any lipid lowering therapy before admission. Of course, you can understand that in this intensification you can consider PCSK9, but I would have liked a more precise indication here. And I'm not happy with the second sentence that initiating combination therapy with high intensity study plus ezetimibe in naive patient is the only recommendation here. Why only statin? We have no new drugs, we have new possibilities. I would have liked a more comprehensive approach. Because that's my last slide. I made this viewpoint that was co-authored by Kosh and my collaborator. And I think I went through the literature based on epidemiological data from imaging studies, intravascular imaging studies, data from registry and from randomized trial. There are all the evidence that going below 55 and 40, I was proposing the same consideration of 40 milligram per deciliter, that this was published before the guidelines, I would emphasize. And I think we are all convinced that there is room of even important further reduction of risk if you go at least in the very high risk patient or extreme risk patients. You can gain a lot of benefit if you go even lower than 55 milligram per deciliter. And I believe that's the way we will go in the near future. Thank you very much for your attention and for the possibility to share this event with you.
Thank you so much, Dr. Professor Velarde. That was beautiful. That was excellent. So it's very uh, not very common that we see a clinical trial data that has been done in intensive settings of clinical trial, and that's kind of reproducible in observational kind of a global registry type of thing. And I think in the field of lipid lowering therapy, this has been consistent throughout, either in the LDL reduction or in the clinical outcome of these patients. So I think you put that in a very elegant way. If you have any question, please drop them in the Q&A. One of the comments here that should we reach maximum doses of other like statin and other medications prior to adding PCSK9, and I would leave that to you to answer. Or should we just go ahead if we're not happy with the level, then we go ahead to add the triple therapy?
Well, you're asking me, right?
Yeah, yeah.
Yeah, I believe that it's the approach that I showed you, the personalized approach, is quite, we can share that approach. That, of course, if you are much distant with a statin from the target you want to reach, it will be useless to go on a stepwise approach, adding ezetimibe. First of all, we in Italy we very most often use the combination ezetimibe plus statins as the beginning, as the first line therapy in patient with ACS. But I would say that would be time wasting and probably patient losing if we go stepwise in a patient that needs to get to 50 milligram per deciliter and is still at 100 milligram per deciliter. Ezetimibe would not make it, and then will make patient not adherent to treatment. So I think we should be more proactive, and when it is possible, as in Italy is, we should be more urgent for reducing LDL to the
Yeah.
optimal level.
And I think that definitely varies based on the health system structure and the insurance type and the etc. For example, in Saudi, we have the government supported hospital that you can directly go ahead and be as proactive as you can. But then in other settings where insurance kind of dictate or private insurance dictate some other things, then maybe not the same luxury. So I do have few points that actually when we discuss amongst us, either cardiologists or our colleagues in family medicine, some question comes up, like not of a doubt, but more of kind of learning more about all type of medication. So now we have multiple options, right? So we discussed the statin and ezetimibe are already established. They're gonna be on board from the get-go. But then we have not one medication of PCSK9 inhibitor, but multiple. So how can we guide our colleagues which one to choose from in these, especially that the data are rich almost, and some of them has older data than others, but there are rich data in all of them.
That's very important point. With the cholesterol story, we are a bit safer than with the other parameters of outcome because we know very well that LDL reduction, any 1 millimole of LDL reduction, no matter how you get it, it's associated with the reduced, with that amount of reduced risk. Although this is not exactly like this, depending on the population of patients. Koshray was showing at the recent EAS that the relative risk reduction for 1 millimole of LDL reduction is higher in patient with lower baseline risk compared to patient with higher baseline risk. But it is independent on the drug you use, LDL cholesterol. So that's why in Italy we started using PCSK9 before the outcome trials, and we started using inclisiran before the outcome trial. So how do I choose? I choose because PCSK9, even from my registry, are very, very powerful, more powerful than inclisiran for as a median reduction of LDL.
Mm.
The monthly injection is a very good compromise between the repetition of this too often repetition of injection that many people would not like, and the 6 months waiting time that probably can lose, contact of the patient with the system, with the health control. And so, in my experience, the 1 month injection is a very good opportunity.
Yeah,
Of
yeah,
course, we will see in a short while the oral PCSK9. We will see in a short while obicetrapib. And as you are mentioning, it's a lot of drugs. Fortunately, we have a lot of drugs. It's a good
yeah.
news. We can treat any patients, actually.
Yeah, absolutely. That was great, and I think we do see that, and I'm sure I know we did not allude to that, but in this presentation, either me or you, but the monthly, maybe you hinted, the monthly dose has been validated for ACS patients as well, and for patients with high LDL and a couple of clinical trials. So between these options, I do believe, and I don't know from your experience and practice, it does affect the compliance of the patient in terms of choosing this. So I think choosing this worth some consideration, given that the patient compliance will be a key factor in the management. I'm having like a few questions came here, and one of them was actually very excellent coming from one of the audiences here. So, and that was one of the point I actually highlighted. So she was saying, given that PCSK9 inhibitor can achieve almost 60% of LDL reduction, comparable to high intensity statin. In her mind, and I think that's a very fair question, what is the rationale of still starting with statin and keeping PCSK9 as an add-on therapy instead of starting as a first-line monotherapy in most patients?
That's very good point because in an ideal world where PCSK9 would cost like a statin,
Yeah,
certainly, I would start as the colleague was suggesting. That would be very good point.
yeah,
Unfortunately, we need, in many cases, we need both. We need statins and PCSK9.
yeah,
And even with that, there is something like 20 to 25% of patients that do not reach the target. In those, we need a fourth drug, actually.
mm,
But it's only a matter of sustainability of the system.
mm,
And of course, as the Dr. Braunwald, I still remember when he said, if a PCSK9 would cost like a pill of aspirin, I would give PCSK9 from 40 years old to all the population of the world. It was very provocative, but he was very right, as
mm,
usual. And it's a matter of sustainability. Uh, but the point is that, and this is an important point, patients do not they do not need to believe that PCSK9 or inclisiran is giving uh, in place of statins.
yeah,
People need to realize that we need combination therapy for that, for their situation. And that's very important in terms of adherence, compliance, as you said.
mm,
And so a lot of patients, discontinue the background therapy because they believe they solve all the problems with the injection.
yeah. And I do believe that despite the significant need of PCSK9 inhibitor therapy, there are some feature of the statin therapy, especially high intensity acute coronary syndrome patients, is essential to be there for combination therapy. Another question here that I think someone is asking, probably it's a patient of his, like in middle-aged man or like actually young patients, 30-year-old asymptomatic smoker, strong family history for cardiac diseases with an LDL 2.8, not that significant, but a lipoprotein of almost 170. Can PCSK9 inhibitor can have a role until we have Pilarcarsin or other
Yes.
aids that coming to the market
Yes.
finish?
Very, very nice question. Thank you. So, for lipoprotein A, in a case like this, and these are cases that will be coming more and more often to our observation because we started to screen for Lp(a).
Yeah.
The only thing you can do at the moment and for a while, because the trial that we will see in the near future are for secondary prevention. And so we'll remain with a lot, the huge population of 20% of the population that has more than 50 milligram per deciliter of Lp(a). What can we do for these patients? To lower more intensively LDL, and therefore you see that the European Society of Cardiology has an algorithm that based on the time of observation in your life of elevated Lp(a), it calculates the amount of LDL that you need to reduce based on the time exposure to Lp(a), to high Lp(a). So you need to reduce more the LDL cholesterol if you come to the diagnosis later compared if you come to the diagnosis earlier, you know? And therefore, this is all we can do. If
Yeah.
we do this with PCSK9, we bring also a 20 to 25% reduction of LP little a,
Mm.
which is, of course, not probably clinically meaningful, but goes in the right direction together with the reduction of LDL. So if this could be done in terms of sustainability, reimbursement, the health system, whatever, let's talk from a scientific point of view. That would be the best, to use
Mm.
a PCSK9 to lower very intensively LDL and to get a bit of reduction of LP-little-A.
Absolutely. And he did mention, he did ask, like, can statin be tried? Absolutely, statin can be tried, but
Can be tried, but they have
not for the
no.
lipoprotein A specifically. It's more for like being aggressive with the LDL reduction.
Yes.
I think about LP little a as an accelerator, and for now we don't have the appropriate brakes, so we're using the brakes we have. This is another question here is in ACS patients. So we move gears to ACS patients. What is the level where we you say, you know what, triple therapy from the beginning? Let's say patient naive, no statin therapy, no ezetimibe in the past, and this is the first encounter coming as an ACS. So what LDL level would you say, okay, this patient will start with the triple therapy?
Okay, the triple therapy uh, gets an LDL reduction of about 80 to 85%.
Mm.
So it's simple. If a patient has the need of, let's make an example. The patient has 150 of LDL,
Mm.
reducing 80% uh, is needed, right,
Yeah,
reach the target. In a case like this, in a naive patient, you can assume that a triple therapy would be absolutely needed to get to target,
yeah, yeah,
considering that whatever can happen is that the patient gets very much lower than the target, but that will be a additional benefit, not harmful for the patient.
yeah, absolutely, absolutely. I see people are getting more interested in the LP little a. So just to answer this question, the last one that came, yes, what he meant is PCSK9 inhibitor can have an effect if it started for that with a reduction of potentially 20%. But the overall goal until we have targeted therapy for LP
Exactly.
little a is to be aggressive with decreasing the traditional LDL and the other risk factors. I'm sure it's getting even late in Italy, and I don't want to keep you even further, but maybe
My pleasure.
a question for the future. Are we hoping to see disease regression?
But disease regression, we have seen already disease regression
Yeah.
with getting very low with LDL cholesterol. So
Mm,
it's not an hypothesis, it's a fact. And
mm,
therefore, that's also, if you read that paper that I was showing, that point of
mm.
view, it's also, something that is adding even more in terms of pathophysiology to the benefit that we observe. These data are clear and they
Yeah,
tell us that all the components of the vulnerability of a plaque
yeah,
get better if you reduce. And to conclude, that those studies were up to 23 milligram per deciliter, like the Pacmanami with alirocumab.
yeah,
The level of LDL that they reached was very, very low, much more than half lower than the target, of course.
yeah.
So
Yeah, absolutely. And someone throw a very good question here. Maybe we can end with that. So, lower is better, and we keep hearing that. So, is very low, is it safe for the patient?
yes,
Yeah.
yes, that's for sure. We know that it's safe, and also recent data in meta-analysis were showing us that even lower than 20 milligram per deciliter is safe. There are no elements of unsafety or intolerability that are coming up. So that's for sure.
Absolutely. I think we covered all the elements.
Thank
And
you.
as much as I enjoyed the presentation, I enjoyed the discussion as well. And we can spend the whole night discussing about this because it's kind of a very interesting, dynamic subject. Professor Pascal, it was very honor for us to have you.
It was
We
my
learned from
privilege
you.
to be with
Yeah,
you tonight. Thank you.
and hopefully we can have you in person in the near future.
I will wait for. I will
Yeah,
be much pleased to come back to
great,
your
excellent,
nice country. Thank you
great.
for listening to me and for this opportunity to share this tonight with you.
Absolutely. You have a good night. Great.
Keep in touch soon. Good
Thank-
night to you. Bye bye. Bye.
Thanks, everyone.